What we did with this project was to evaluate the use of guideline-directed medical therapy for comorbid conditions in patients with atrial fibrillation. We know that atrial fibrillation is a growing problem in the U.S. and that it is frequently coexistent with other cardiac comorbidities such as CAD, diabetes, hypertension, high cholesterol, and we were interested in both how well those comorbidities are treated in AFib patients and what the association between treatment of those comorbidities is on outcomes. So we looked at a registry of ambulatory AFib patients in the U.S. called the Orbit AF Registry, which has more than 20,000 patients in it. And we evaluated the patients who had had an additional comorbidity for which there's professional guidelines for evidence-based therapies. And then we looked at the rates of those therapies as well as the association between those therapies and clinical outcomes. Some of the key findings that we found in the study were that 2/3 of patients are not on all the medical therapies for which they're indicated. Only about 33% are. That's a little bit lower than I think we had expected. Based on prior studies, we thought it was probably closer to 40 or 50%, but that's pretty substantially lower than that. Adherence to different guideline-directed medical therapies varied based on which comorbidity you were looking at. Hyperlipidemia, for instance, had more than 70% of patients appropriately treated with statins, whereas diabetes patients were only treated with all of their eligible therapies 43% of the time. The other interesting aspect of this project was instead of just looking at the prevalence of GDMT, or guideline-directed medical therapy use, we also related them to outcomes. And so we looked at the association between being on all of the therapies for which you're eligible and different clinical outcomes, including all-cause mortality, MACNE, which stands for Major Adverse Cardiac or Neurovascular Events, cardiovascular hospitalizations, as well as progression of atrial fibrillation. Looking at the outcomes analyses, we found that there was a trend towards lower events of all-cause mortality in MACNE, or Major Adverse Cardiac or Neurovascular Events, with use of all eligible medical therapies, but they didn't quite meet statistical significance. To explore this further, we broke down the use of GDMT by comorbidity, and we looked at all the outcomes within each comorbidity group. The treatment with GDMT for heart failure specifically was associated with a 23% reduction in all-cause mortality that was highly statistically significant. And that's really interesting because it tells us that there's an interaction between the comorbidities and outcomes with atrial fibrillation patients. And specifically, this relationship between atrial fibrillation and heart failure is really interesting in the context of some of the other data showing that catheter ablation for atrial fibrillation may improve outcomes amongst heart failure patients. And it makes us kind of think about the interrelationship between those different conditions. Treating one has effect on the outcomes of the other. We also noticed that for patients with obstructive sleep apnea, use of CPAP, or continuous positive airway pressure, was associated with a reduction in the progression of atrial fibrillation from paroxysmal atrial fibrillation to persistent. This is something we've heard a little bit about in the literature, that treatment with CPAP for OSA patients can help reduce the symptom burden and progression of atrial fibrillation, and it was reassuring to see those results in this analysis. I think that when you look at the trends of who gets all the therapies that they're eligible for, we see that there's discrepancies, as we've seen in many other large registry data, where men tend to get more of the treatments for which they're eligible, as well as people of white race. This is consistent with many of the other large registry data that show that there's discrepancies in treatment patterns, but it also may be reflective of difference in disease severity. We noticed that the people who are on all eligible therapies also had fewer of the comorbidities that we were evaluating, so they were in general kind of a less sick population, and it may be that their physicians felt more comfortable prescribing them more therapies, or all the therapies that they were eligible, compared to a sicker patient for which you may want to move slower and more gradually with. I think that the overall evidence suggests that if you can get someone on all of the medications that they're eligible for before, they will have a better outcome. Now, this is a retrospective observational study, so we can't make any causal claims saying that the use of these medicines is driving the outcomes. We just can comment on the association of them. But I think that when we break it down by comorbidity, we see the importance of certain conditions are highlighted. For example, heart failure, where we see an association between the use of guideline-directed medical therapy and outcomes.